the description of the vehicle, like what color, make, and model?
Public safety is in the spotlight in Seattle, facing a record number of homicides and an opioid epidemic, all too visible on the city's streets.
And this is the worst drug crisis I've ever seen in my life.
But reports show nearly 4 out of 5 911 calls in Seattle are for non-emergency incidents.
Often we don't need a gun and badge. We need people trained and skilled at the kind of outreach and kind of treatment that we want to see.
Will a new dual dispatch program get help to those who need it and free up police to focus on more serious calls? And what lessons can be learned from a similar program from Seattle Fire?
We can't just take everyone to the emergency room.
Our panel weighs in.
Our average response time right now is 5 minutes.
We find ourselves policing a lot of social issues.
How is Seattle's approach to public safety changing? Some answers next on City Inside Out. And joining me to discuss these issues of public safety and community well-being, I have the chiefs of Seattle's 3 public safety departments, including Amy Smith, acting chief of the new CARE department. That's Community Assisted Response and Engagement, known as the 3rd Public Safety Department, but you're number 1 right here, Amy. Thank you very much for being here.
Yeah, happy to be here.
And also we have with us Chief Harold Scoggins of the Seattle Fire Department. Chief Scoggins, good to see you too.
Good to see you.
And also with us we have Adrian Diaz, the chief, of course, of the Seattle Police Department. Chief Diaz, great to have you here.
Glad to be here.
All right, let's jump into it. And I think a lot of Seattleites know these guys, but they might not know you as well. So I want to break this down with you, Chief Smith, if I could. Can you describe what CARE is? And I'd really like to focus on the dual dispatch pilot program that you launched at the end of October and how that's changing the way the city responds to emergency calls.
Yes. So CARE has been organized as the 3rd Public Safety Department. The genesis of the concept is really just anchored in 911 data. If you look at all the calls that come into 911, how many do not require or involve fire or medical transport or police, some kind of enforcement? And this is a national trend. If you look at the calls, about half don't necessarily require either team. And I think as we've become culturally more sophisticated, understanding behavioral health, understanding mental health crisis, how to be really culturally sensitive and responsive to groups, you realize lots of different types of professionals might be best suited to certain call types. And so you really need to organize not just a little pilot or another, sub-team in a department, but actually just set up a new department. And so that's what Seattle has done. This has happened in some other cities, but what Seattle is doing, I think, is the most significant because we also, in this department, we house Seattle 911, so that's kind of like the data hub.
Right.
And then we'll have diversified response teams, and that's what the first CARE crisis responder team is. And then we will also house an Office of Violence Prevention, where we're really thinking about early intervention and prevention strategies that don't need to sit in the police department.
Okay, thank you for breaking that down. And we'll get into the nuts and bolts of it in just a minute. But Chief Diaz, maybe I can go to this question next and expand on what Chief Smith was saying, just why the response to emergencies is changing. Because the SPD asked the National Institute for Criminal Justice Reform to study its 911 calls. You found out last year nearly 80% of those calls were for non-emergency incidents. So I think the idea is if CARE is in place to work on these lower acuity calls, like they're called, the person down, that frees up officers, which I know are in short supply here, to respond to more serious kind of criminal calls, right?
Well, that's actually the significant trend. We know that many of our police departments are actually getting smaller just because of people leaving major cities and other departments throughout the country. So we've actually had to really be able to assess, like, what are our calls for service? What are we really focused on responding to? And we find that there's a lot of calls that are just not made for, or not designed for the police officer to respond to. And so that is the reason why it's so crucial to have other partners at the table to be able to take on some of that workload. We've actually, prided ourselves over the last, 27 years that I've been on the job, but even before this, we've built programs. We've, had community service officers. We've had mental health responders that are respond with officers. But really, some of this work is not really designed for policing. We find ourselves policing a lot of social issues, and that's not where police should be. We want to focus on the crime, and now we know that there's impacts from the social issues that do create, crime, but allowing us to just focus on the crime. And I think what happens is over the course of my career, a lot of police departments said, well, no one's taken on that work, so we need to do it. And honestly, I think now we're starting to realize we just don't have the staffing to be able to do that. And we honestly don't have the skill sets to be able to do that too. I'd rather have mental health professionals work with people in crisis. That doesn't mean that we can't be a component of it, but I really wanted to actually say, let the professionals that go through schools, training, and all those other things for years on end do that work.
Okay, thank you very much. And Chief Scoggins, I wanted to talk to you about this because the Seattle Fire Department has been doing very similar work to this with Health One, SFD's Mobile Integrated Health Response Unit, launched in 2019, combination of firefighters and case managers from the Seattle Human Services Department. You help people get medical care, mental health care, maybe even shelter if they need it. And I think it's a similar situation to SPD's because in 2018, the fire department found that 42% of its calls were low acuity. So I just wanted to talk about this. Why is Health One important for your department, and how's it been working?
You know, Health One's been working great. You know, we're 4 years into it last month. Like you said, we started in 2019, and we saw a need. Many of our responses were lower acuity medical responses. So it didn't require that lights and siren, fire engine, aid car, medic unit going down the street, but it did require some help. And we had so many of those that they have been overwhelming the system. So what we have right now is 2 firefighters and a case manager, and they do an amazing job. And they're able to spend the amount of time that's needed on scene to figure out exactly what the person needs. And sometimes that takes 15 minutes, and sometimes that takes an hour and 15 minutes. Sometimes that means that they're going to be going to shelter, or sometimes that means that they're setting up an appointment for a medical appointment 2 days later. They do all of those things. They have vouchers for Lyft. They're able to reconnect folks to their case managers or healthcare workers or families. All of those things that you can imagine, that's the gap that they stand in for the fire department, which is very important because they leave our fire engines, ladder trucks, medic units, aid cars available to run those critical medical emergencies.
Got it. Thank you. And Chief Smith, I want to make sure I break this down, what it looks like when someone calls 911 and what resources get dispatched where. So you run the show there. When does a 911 call turn into a dual dispatch situation or a Health One situation? What does that look like?
Yeah, so in 911, what we want to determine right away is if there's a serious medical condition or threat, and then it goes right to the fire alarm center. And then they take it from there, and they determine what response to send. Is this fire? Is this Health One, Health 99, nurse navigation? There's an array of resources on that side, so that's the primary question. If it's not going to the fire alarm center, again, the question is it an emergency? Because we can divert to non-emergency. We've got 988 online now, too.
Right, suicide prevention, yep.
Right, exactly. But then the question is, you know, is this a priority 1, which means a significant threat to life? That's what priority 1 should be. So we are cleaning up some of the call types and driving stronger protocols to make sure that, you know, from a space of fear and cynicism, we're not calling everything priority 1. So an officer once said, Amy, if you make everything priority 1, nothing is priority 1. You know, and that was actually a very impactful thing for me to hear early, that we need to be very thoughtful about that in the space of a lot of crisis, a lot of violence, that we don't miscode, basically. So is it priority 1? Is it priority 2? Where, again, there is an urgency. There's a higher acuity, a concern for public safety, potential threat of violence. But then as you go down, priority 3, we've ruled that out. The call takers are very thoughtful. There's rigid protocols, you know, answering questions and trying to surface what the caller is observing usually. You know, sometimes we're calling on our own behalf, but often somebody's just seeing something and feels concerned, feels like they should call 911 is, you know, often it just sounds like a compassionate bystander to me. And so people ask me what types of calls, and when I'm sitting in 911, what you often hear is, you know, I'm on this corner, he's slumped over, he doesn't look like he's doing well. And so then we're trying to surface, is this an overdose? Is this a heart attack, a medical condition? But often it's not. Often somebody's crying or they're muttering, they're in distress. It seems like they're not safe. Recently there was a call where somebody wasn't clothed and it was 28 degrees outside. So we could see that there's no weapon here, there's no violent behavior. behavior, but we must send someone.
Yeah.
And so again, who would be required in that situation?
Okay.
Right? And so I'm trying to create capacity for both of these two teams who are highly skilled and really need to be reserved for high priority calls.
Got it. And Chief Scoggins, maybe I can add you to the mix here, because I wanted to figure out how your Health 1 units get dispatched, because people can't call Health 1 directly. It has to come from 911, right? 911. I just wanted you to describe how this looks.
Sure. Once the call leaves Amy's shop over at the 911 center, if it's a fire medical emergency, generally these calls are in the medical category. Then we get it and we triage it. So our dispatchers go through a series of protocols and all the Q&A with all the person on the other end of the line, and they'll determine if it requires a full lights and sirens response with medics, EMTs, and fire engines, or can we deploy Health 1, or can we send it to our nurse navigation line?
Okay.
And so oftentimes, Health 1 is directly dispatched from our fire alarm center. So that's one way you can get them. Mm-hmm. Or if they go, they treat you, they build a relationship, and they reconnect with you, we actually do case management on Health 1. So there's follow-up that takes place the next day, the day after, to make sure you got your meds filled, to make sure you got your appointment. If you're an older adult, we have a vulnerable adults program.
Okay.
So we go and check to make sure they're getting what they need. And the reason why that's important is if we do not do these things, they will be a 911 emergency where you do need the medics and all of the skills that we have.
All right, thank you, Chief. Chief Diaz, I wanted your take on this, because your officers go out with these behavioral health specialists from CARE on these dual dispatch calls. I'm just trying to figure out, what is the officer's role in those situations, and also when and how can an officer decide, okay, health specialist, you got this, I'm moving to another call. What does that look like?
Yeah, it's just like any other call. What the fire department does, it's triaging. It's really assessing, is there harm, and what is that harm, and and when I say harm, I mean, is it a safety issue, and is it a safety issue for the care workers to be able to proceed? And a lot of these situations that we have that dealing with people in crisis, or what we refer to as sometimes people down calls.
Yeah.
Where somebody's literally, it's probably because of an alcohol intoxication. Could be a drug issue. It could be a variety of different things. It could be just people sleeping on the sidewalk. Yeah. And officers are having to go to that, and they're like, what resources are we going to provide?
Right.
And there's no safety. There's no safety issue. So, they're going to end up making that assessment to say, well, CARE, it's better in your department.
I guess I always get this question, though, when I talk to people about dual dispatch. It might seem like this situation is under control, but what if it escalates in some way? What happens then? What does that look like?
Yeah, you can already start to, officers are already assessing those situations. They're very much on the front end. You can tell when a person's, can have triggers or agitation in the call very early on, just by them showing up. And sometimes the officer might actually sit back and let the contact be the care department initial. And if they start to see, okay, this person is already aggravated, and then I'm going to end up stepping in, it might end up being that the officers, are coming on scene, and the person actually might be aggravated by the officers, and they might just say, and they might just say, it's best for us to just step back, let the care people assess, and we're just going to stay away, and we're not going to leave the scene, but we'll just let them handle it. So again, everything is a case-by-case situation, but officers have done this for a long time. In fact, they've been doing it. They've been handling those calls, and they're like, at this point, it's better for another department to start taking leadership in it.
Chief Smith, can you just talk to me about this from a dispatcher kind of a situation?
Sure.
All right, this call comes in at first classified as lower acuity, but then something escalates. How does that work in terms of how you're communicating?
Yeah, well, there's two ways the care team has been responding. The first way is that police go to a call and then they say, "Is the care team available?"
Yeah.
I hear it all day long. I'm listening to the radio, and it made me smile because I didn't know if police would have trust in that new resource right out of the gate. But week one, I heard it all the time. I'm hearing requests for the care team from officers sometimes at 7 or 8 in the morning, and we're not online yet. We're coming on at 11. But I'm very happy to hear that it's going well. the feedback loop is in place with both of these departments, and then with other folks in the field and Human Service Department. So we're having these coordination meetings. So that's one way. That would be secondary response. And again, police have been doing this for a long time. They've had CSOs that they invoke. They've worked with the King County Mobile Crisis Team. And so it's not as confusing on the inside as people assume that it would be. It's exactly the same protocol. It's just swifter. It's a swifter dispatch model. So dual dispatch, if our dispatchers say, this is a good thing for the care team, sometimes it's a high utilizer. And we're on police.
Someone who might call 911 a lot.
All the time is consistently in distress, and we can see in our notes that there's never been a threat of violence, that there's a sort of a chronic issue, and we know how to respond. And in that scenario, police they're given situational awareness. They're on the channel, but they can say, care team, take it, let us know if you need anything. So all folks on the front lines of human behavior and crisis response were really well trained to know when to take a step back, when to not proceed. And this happens between these two departments already. Often fire will be going in, and then they'll realize, no, we need to be partnered with our officers first.
I was going to ask for your take on this, Chief Scoggins. Have you been able to respond with Health One, but then it's turning into a larger emergency? Talk to me about those two pieces.
Well, sure. I think this happens every day between police and fire. We go on so many calls together, whether it's a scene of violence, whether it's an overdose, whether it's a really bad traffic accident. We're always working together in the field, and we've been doing that forever. And I think we do it really well. We support each other. We'll call for PD when we need some assistance, or they'll call for fire when they need some assistance. So it's been happening, and it'll continue to happen with Amy's team, because there's a lot of people out there that need help. And what you can see right here is we're trying to figure out what help you need, and that'll determine on who's sent.
Thank you. And let me, Chief Scoggins, I'll stick with you on this one. I want to try to talk about some of the challenges involved with this work. I think about this. Your crew meets with a patient, takes the time to deal with their needs, and then what next? Because you know it and I know it, our region has a shortage of receiving facilities, drug and alcohol treatment centers, nursing facilities, shelters, et cetera. How does that shortage impact the work of Health One?
Well, it's a significant impact. Places to take people is our rate-limiting step each and every day. We can't just take everyone to the emergency room. People need so many different things. Someone may need a shelter bed, and the shelters may be full. Someone may need a place to go for their substance use dependency, and we want to get them there, and that's what our Health 99 team has been doing since June, and that's the overdose response team. But what they're seeing is there's just not places to take people, even when we get them to yes, that I'm ready to change my life, I want to get some help, I want to get off of this, whatever this is. Oftentimes our challenge is finding a place to take them. And so that's our rate limiting step. I know a lot of work is being done on this space. It just seems like a slow walk when you're running the calls every single day and you're running into the same barrier every day.
And is it a deal where it's like, okay, we'll check in with you tomorrow, we don't have that space right now? Is that what it turns into?
It turns into all of those things. We'll check in with you tomorrow, we'll follow up with you, let's get your cell phone number, because if someone is unhoused, then sometimes it's difficult to try to find them the next day. And so when they have a cell phone, we work hard, but we carry a lot of things to build trust and relationships, whether it's snacks and food and socks and water, and on cold days, blankets and all of those things. All these interactions help us build trust, and our team has great relationships. Each day, we have 2 Health One unit teams on the street, and we have Health 99, which was our 3rd Health One unit. But that unit is running overdose calls all day long. And their #1 goal is to try to figure out how to get people to transition into a different lifestyle.
And maybe I can jump off of that and go to you, Chief Diaz, because I did want to talk about the fentanyl crisis that our region is in right now. And as you know, we had a big public debate in Seattle over the past several months, creating a gross misdemeanor statute on public drug use and possession. I just wanted to make sure I broke this down, because you got some people out there saying, lock them all up. And then you got other people saying, we don't want to return to the war on drugs. I guess I'm just trying to figure out, how is the SPD approaching our drug crisis? How are partners like CARE and the fire department helping out?
As I mentioned earlier, we talk about us policing social issues. Drug and alcohol addiction are much of a social issue. I mean, now there are criminal activity that occurs as people sell, and it creates a black market system, and you have a variety of crime activity that's associated with that. But the actual addiction is really something that we find ourselves having to police. And so, really is working with the mayor's office, city council, and other community partners in this, we all had a seat at the table to create this new drug usage law. And we really identify harm and no harm. And when there is no harm, somebody's in an encampment and they're, smoking fentanyl, we still want to get them into services, but we're not going down the approach of an arrest.
Okay.
But when there is harm, when we know that, we can look at 3rd and Pike or 12th and Jackson or, other areas in our city that there are a lot of harm that, school environment of kids going walking through these areas, shopping districts, criminal activity that's associated with it. And we know we can identify quickly that there is harm. And so that is where the officer can come in and make that, contact. We might refer to it as an arrest. But our sole goal is to get them into services. But what we're finding is that people have also have issues of warrants. We've recovered a rape warrant, we've recovered assault warrants, and we've actually recovered guns. And so there are other things usually sometimes can be associated with that. But at the end of the day, if there is somebody that is willing and wanting to get services, we are hoping them to connect into a variety of different programs. And that's where our officers' goals are.
Right. You can't arrest your way out of this.
Exactly.
Is definitely what I'm hearing here. Thank you for breaking that down. Chief Smith, I wanted to talk about a challenge that I'm seeing with Karen. You touched on this earlier, just the size of it. You got 3 teams of 2. They've got certain hours that they're working every day, 6 employees out there working in this downtown core area. I guess I just wanted to ask, is that going to be enough to make a dent, to make a tangible impact on public safety?
No. It's a meaningful step forward because the department is organized now. This was legislated, right? We have these new first responders in the city, so it's incredibly significant, and I feel that. But I'm always quick to say with police co-response, with Health 1, Health 99, we are woefully inadequate to respond to the crisis. I think folks feel like, oh, we've got a team now. No, it's 6 people, and this is shift work, and so I don't even have all my 6 people in the field at the same time. We would need to scale significantly, but we also need to coordinate efforts. We're all in conversations about what else could be dispatched. We have great community service officers. Could we dispatch them from 911? That's happened in the past. Could we do that again? So looking at the whole system, what does the nonprofit sector have to respond? What does the public sector? Are there other private entities, groups? We've got We Deliver Care, teams like that. And I'm really having fun in the role because a lot of it does feel like air traffic control a little bit, and it also, I like analysis.
Okay.
Just
you have a different idea of fun than I do, but keep going.
Right. I've been told that before. No, I'm having a really good time because I love figuring out how do you really audit every asset you have in community, get everyone in a room, and then figure out who does what the best, and then where are the gaps.
Right.
And then you start to scale. And so even right now, I'm not recommending that I scale this team. I want to stitch together the continuum of crisis response, and I may make the recommendation, no, we need more co-response. We are in a fentanyl crisis right now. We have 1,200 overdoses. So even when we talk about record homicides, that is so significant and so tragic, but 1,200. So back to your question about, criminalizing addiction and things like that.
Sure.
Of course I don't want to do that, but we have to intervene in a way that people have a chance at life. And fentanyl is not the same as other substance use disorders.
Yeah, very true. Thank you. We need to start wrapping up here, and you were going down a path that I'd like for you to keep going, if you could, Chief Smith, because I want to try to figure out how to measure success in your work in public safety. A few months from now, will it be our teams have responded to X amount of calls or gotten X amount of people into drug treatment? What does success look like for you?
Yeah, in the short run, what we're really looking for are outputs. We're not going to have outcomes yet because, again, we don't have a system set up to receive people in a way that could provide a meaningful intervention where your life is redirected. We don't have that yet. I'm looking for response time right now. Can police and fire get to more priority 1 and 2 calls more efficiently? That's very easy to track. I'm looking very carefully at the care metrics. Our average response time right now is 5 minutes. Now, in part, that's because we're in a small geographic location. Qualitative data. Did you feel safe? Did you feel equipped to respond? Were police needed? Do police perceive that this is a useful step forward? On the community level, I'm with a lot of neighborhoods in the business community, and really what I'm trying to assess for myself is hope. Do we have a sense that things could be better than they are? because I feel like our communities are disenfranchised, we're discouraged. There's a lot of grief and loss and sadness that hangs in the air when you walk around knowing that we've invested millions of dollars, and why is it getting worse? So it's, again, a meaningful aspect to the work to be in these conversations. I recognize that even just our true collaboration and respect for one another and coordination, that is hopeful to people. It's significant, apparently, you know, that this mayor's office is insisting that we really are collaborative, and that the mayor's office will collaborate with council.
Yeah, it's important to hear that. Thank you very much. Chief Scoggins, just some thoughts on measuring success. You've had some success with Health One. Where does that program need to go? Your hopes for this team up we're talking about right here.
Yeah, you know, some of the ways we measure success is what Amy just mentioned is, are we keeping our emergency response units available? That's one. Another area is, are we helping people? We're able to look and see how many vulnerable adults did we actually help? How many times have we reconnected someone with their case manager or their family? How many people have we actually gotten off the street and into a shelter bed? These are just some of the ways we measure success, and we can look back on that. In 2022, we had over 1,100 direct dispatches, but over 2,700 referrals that were made by the firefighters in the field that we went and did follow-up on because people needed help. All those are ways that we measure success.
Thank you. Chief Diaz, I'll have you wrap up, and I've talked with you about metrics of success in a lot of different ways. You're trying to reduce response times for top priority 911 calls. You're trying to hire more officers. You're trying to develop a culture of more compassionate and equitable policing. You got a lot on your plate, I know. Focusing on the work of this group at the table here, how are you going to gauge the success of what's happening here?
You know, well, our boss immediately always says the #1 charter for the city is public safety. And for us, it is literally making sure that people feel safe in the city. And I know I walk the areas. I actually drive by some of these locations every single morning as I come into work to get an assessment of what it's going to look like for the day. And so, you know, we look at, there's really both sides. There's the qualitative metrics. How do people feel when they walk in the streets? Do they feel like there's disorganization? Do they feel safe? And then there's the quantitative, which is all the stat stuff, and we're monitoring both. I looked at my stats just for 2018 as a comparison, just 5 years ago. We're actually on the same violent crime trend as 2018, but I had 31 homicides in 2018. I have 71 right now. And so, like, why is it, when you're looking at almost 5,000 cases, why is the difference between 40 homicides? You know, when we look at overdoses at a record high, almost 4 times what we had just a couple years ago, you know, we got to figure out what policies in place that we're actually doing that is there a contributing factor? Are we working with the prosecutor's office? Is our criminal justice system working? Is our partnerships working with, you know, getting people into the right services and connected? So there's a variety of areas that we're still looking and making sure that we're actually measuring the right metrics.
Right.
But there's still more to measure.
I was going to say, to be continued. There's a lot more to the story. Thank you all for your input, and everyone watching, thanks for your input too. What are people saying on social media about public safety in Seattle? One person writes, I hope this dual dispatch pilot project works, but I also run a business in Belltown and know it's not going to be as easy as some people think. Another person comments, do you know what will make us feel safe? Get the criminals off the streets and put them in jail where they belong.
We'd like to know what you think. Send us an email at contact@seattlechannel.org or find us on social media.
I'm Brian Callanan. Thank you for joining us right here on City Inside Out on Seattle Channel.